Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Today, I am joined by Dr. Casey Sarapas, a research scientist at Chestnut Health System's Lighthouse Institute since 2021. Casey's work focuses on evaluating systems of care for behavioral health with an emphasis on high-end underserved populations. He collaborates with Lighthouse Institute and external scientists across several projects covering data services, statistics, research design, reporting, and dissemination. I should add that Casey sent me his bio, which goes into considerably more detail, but for purposes of brevity, I guess we could leave it there. Casey, thanks so much for joining us. Appreciate it.
Thank you, Charles. It's great to be here.
And you were calling in from where exactly?
I'm calling from DeKalb, Illinois, which is kind of a half university town, half kind of a farm town, hour and a half west of Chicago. I think its claim to fame is it's the birthplace of modern barbed wire.
Modern barbed wire. That is interesting. I'm going to hazard a very lame joke, but being a New Yorker by birth, we specialize in barbed comments. So we'll leave it there. Anyway, Casey, again, I really do appreciate it. Before we begin, congratulations in order. Each year, the editors at JCAP Open select a small number of standout studies they consider the best of the year. And the study titled Predictive Validity of the eConnect Suicide Risk Classification Algorithm in Youth on Probation was selected, which of course you led. And it was selected as one of the editor's favorites among studies published in 2025. So again, congratulations, Casey.
Thank you.
So today, I kind of want to dig in to that study. But first, for our listeners unfamiliar with eConnect, describe what it is that prompted its development for probation settings.
Sure. So, briefly, eConnect is a digital clinical decision support system, which is designed specifically for, as you mentioned, juvenile probation settings. And I want to unpack a little bit what that actually means. But, first I'll touch a little on what you also asked, kind of what prompted it and what prompted it specifically for these settings for, youth who are in juvenile probation. So the motivation really is that youth on probation have really extremely high risk for really all kinds of behavioral health problems, but chief among them is suicide. So we know that just in youth in general in America, suicide risk is really alarmingly high. About 1 in 10 youth report attempting suicide any given year. But for youth who are involved in the criminal legal system, that's even higher. 1 in 4 youth who are in the legal system report a suicide attempt in the past year. So the need clearly is huge. But despite that, we also know that currently a lot of youth who are on probation who do have real risk are not even being identified. A lot of probation agencies don't have any kind of standardized screening to identify who's at risk for suicide. And then even when youth are identified as having, a need for behavioral health treatment, studies that have been done show that only about 20% of those youth actually receive a referral to the treatment they need. And, as is often the case in many settings, that rate, even though it's abysmally low, is even lower for youth of color. So clearly there's a need, and that need isn't really being met. And then so specifically just looking at staff, it's really probation officers who are at the front lines of this. They are obviously the main kind of main people having contact with young people and their families who are on probation. Generally, it falls to them to assess, if a youth is at risk or has treatment needs, and then to figure out what to do about it, what kind of services they need, how to actually connect them and get them into services, all of which is a really big ask, but often, probation officers just aren't given the tools and the resources they would need to actually do that well. They're not trained as clinicians. That isn't they're at least in their job description. They have usually huge caseloads, very limited time even to assess youth, let alone, trying to then navigate the mental health care system and try to connect the youth to services. So, it is really a huge ask for, these folks who are working at the front lines of this. So,
yeah, I do want to come back to that.
Yeah,
We want
yeah,
to come back to
absolutely.
that. So yeah, that's a critical element in all of this, obviously. So you kind of already touched on this a little bit. I was going to ask you what prompted you to undertake the study in the first place. What were the gaps in
Mhm.
research and practice? So if you can expand on that a little bit.
Yeah, yeah. So, I mean, given that context, that we were just talking about, that's really what motivated the development of the eConnect system in general. So, I said it's a clinical decision support system. So, what that really means is it's really kind of a combination of three components that work together.
Hmm.
One is it's just a brief youth self-report screen, which I can talk more about, what that contains. But basically, this is
Yes.
like 20 items that, youth on probation is completing themselves, on a tablet, that assessing, mental health symptoms, substance use, etc. So that's component one. Component two is a risk classification algorithm. So all that means is we've developed basically some decision rules that, based on how youth are responding to the screen, is looking at those responses and then using that information to assign them to a level of risk, of suicide risk. So saying, based on their responses, we think this youth is high risk
Hmm.
or at some risk or, not at risk. So that kind of takes away the requirement for someone, a probation officer, say, to be an expert, mental health clinician who's looking at this and providing interpretation. We kind of automate that interpretation piece. And then the third component is linkage. So anyone, even people who have the resources, who has tried to get mental health treatment for themselves or for a loved one, knows that it can be a really difficult system to navigate. And I think that goes 1,000 times for the youth who are often in probation settings. So the third piece here is that we are, really, and I should mention that eConnect primarily was developed by our partners at New York State Psychiatric Institute and Columbia University. So Dr. Kate Elkington and others. So, their team kind of works with each probation agency and with behavioral health in the area to kind of establish these referral pathways. So for youth who are at kind of this level of severity, they can be referred to this specific agency, and here's how you do that so that it is much more streamlined in the moment when a youth is
Yeah.
identified as needing, yeah.
FYI, we did have Dr. Elkington on this podcast. We had a very interesting conversation. I asked her something I want to put to you
Yeah.
in a moment, but it sounds like you're about to say something else.
Yes, I'm trying to eventually get to actually answer your question. So for this particular study, so that's eConnect. For this study, we were really focusing on the second of those components. So I mentioned there's the classification algorithm, right? So we're trying to identify not just is this young person at risk or are they not? Because, we know in reality, it isn't necessarily black and white. There may be someone who is really at very high imminent danger of, making a suicide attempt. Someone else, while they're not at that level, may still have some real risk for, attempting or completing suicide in the future. So we really want to kind of capture the level of risk so that we can, rather than saying, well, we're going to take the most severe kids and send them to the emergency room and then everyone
Right.
else gets nothing, trying to connect people to the level of services that actually make sense for them.
Right. Yeah, my understanding there are 4 risk classes.
Yeah, that's right. Yep. So basically, youth get classified either into below threshold. So they don't seem to have any need for treatment. Class 3, which is they definitely have behavioral health problems that need treatment, and they can be referred on kind of a routine basis to get treatment in the near future. Class 2 is there definitely there's a concern for suicide risk. It isn't immediately imminent, but those youth need to be prioritized and seen within 3 business days is kind of the criterion we use for that. And then class 1 is sort of the most severe. These are youth who, based on the algorithm, we think really have the highest level of immediate risk, and need to be, either seen in the ED or, within 24 hours.
Yeah, so my understanding the algorithm combines severity, recency, and patterning in assigning those levels of risk.
That's exactly right. Yeah. So, screeners or scales that exist. Basically, you have a bunch of questions and then you just kind of count up how many did the person say yes. And then if it's over 10, then it's significant. This is kind of a different approach where it's not just looking at like what's their, total score, but looking at, okay, how recently are they reporting they had suicidal ideation or thought about suicide? How recently have they had a problem with substances? Because, it may be obvious, but like if someone is reporting they're currently using substances, that probably indicates more risk. But, even if someone had significant substance use problems 6 months ago, they may not be using right now, but that still indicates some risk. They could relapse in the future. And obviously we know substance use is a huge risk factor for suicide. So, looking at recency is important. And then you mentioned patterning. So yeah, that's really the idea of like, there are some symptoms in combination are really increased risk more than they might on their own. So, again, looking at substance use, the combination of someone who has some history of, at least thinking about suicide or planning a suicide attempt, along with a current substance use problem, that's going to put that person at much higher risk than someone who just has a substance use problem alone, or, maybe even someone who has had some suicide ideation, but doesn't also have substance use. They combine to make risk, and the kind of the algorithm accounts for that combination of as denoting higher risk.
I want to ask you about its predictive accuracy, but before I do, we kind of gloss over. We mentioned there are three components: the initial questionnaire or assessment, the classification, and the linkage. But we kind of glossed over the first component, which my understanding is based on the GAIN, the global appraisal of individual needs. For those listeners unfamiliar with the GAIN, just if you would give us a high-level description of what it is, how it's used, and what that measures in
Yeah,
the
absolutely.
context of this program.
Absolutely. Yeah, yeah. So the GAIN is really kind of a family of instruments developed here at Chestnut Health Systems by Mike Dennis and his team. And it is, basically a set of tools for assessing uh, behavioral health needs kind of broadly. So, obviously things like mental health, substance use, physical health, but also, the full GAIN looks at things like school functioning, work functioning, motivation for treatment. Um, but so I refer to it as a family of instruments. So, there is like a full GAIN interview, which, can take 30 or 60 minutes to complete and touches on all these areas. There are also other shorter forms. There are kind of short screening forms that were more the basis for the screen in this study. The one other thing I want to mention about the GAIN is it has, it's been pretty widely used, but in particular, it's been used across a lot of juvenile justice or juvenile kind of criminal legal settings, and so we have a lot of data that this is an instrument that does work well to assess people in the criminal legal system in particular.
My understanding is that also there are about 20 GAIN based items that are included in the eConnect system.
Yep. Yeah, exactly. We basically, so I mentioned there's an instrument called the GAIN Short Screener, which is, a set of scales that are, validated for getting kind of a quick snapshot of, mental health symptoms, substance use, like kind of a few key domains like that. So what we did is we adapted some of those scales and pulled in a few other items from other GAIN instruments to basically capture domains that we know, just based on the literature, are kind of the strongest predictors of risk for suicide. So that's mental health symptom. So I guess I should back up. We know basically across any behavioral health or psychology, the strongest predictor of a behavior is almost always going to be that same behavior in the past, right? Past behavior is the strongest predictor of future behavior. So, obviously we're asking about directly, suicide ideation. Have you ever made a plan for suicide? Have you taken steps towards, a suicide attempt, gathering means? Have you attempted suicide? But then we're also bringing in other things that are less direct, but we know associated with risk. So that's where we're looking at mental health symptoms, substance use, things like that.
I said I want to ask you about the predictive accuracy, and I do. I also mentioned that I had Dr. Kate Elkington on the podcast, and the question I asked her is you're asking you to self-assess based on previous instances of suicidal ideation, et cetera, et cetera. And what I asked her, and I'll be honest, I don't remember exactly how she responded to this, but how can we trust youth to give an honest, candid answer to these questions, knowing full well that across the board, regardless of the cohort, that people do tend to give you answers that you want to hear. They can tend to game the system. It does sort of go into the predictive accuracy question, so I'll get to that in a moment. But what would you say to that?
Sure. I mean, that's a real concern with any assessment. I think some of it can be addressed by the tool. So, even the fact I think that it is just self-reported as opposed to administered by, a probation officer or someone else, I think does help to some extent. I think there's some just from research showing that, in some cases people feel more comfortable disclosing things if they're just kind of filling something out on their own versus, actually talking with another person face to face. And some of our colleagues, Gail Wasserman, who's also on the eConnect team, has done research specifically looking at, well, how accurate is reporting among youth who are in the justice system, and finding that, it's pretty accurate. And I believe in some cases, like youth ratings, kind of reporting their own behavior or their own, whatever it is, ends up being more accurate in predicting things than, for instance, probation officer ratings. So often youth have more insight to what's going on than someone else from the outside. So I think that's part of it. Yeah, I would be actually. I did listen to some of your conversation with Kate Elkington. I would be interested to hear what she said to that question, because I'm sure.
Yeah, we got to go back to that. I'm gonna have to unearth that.
Yeah.
So predictive accuracy. Is prediction accuracy per outcomes like attempts and ideation was better, according to your study, than many other suicide risk measures in similar populations. Explain how you arrived at this.
Yeah, for sure. So first, I want to be cautious about saying that our tool is definitively better than other tools, primarily because, we weren't doing a head-to-head comparison where we're, using multiple tools in the same sample, which I think is what you'd really need to make a rock-solid claim to that extent. So I do want to be careful about that. But that said, so we did look at how well our classification predicted risk in a few different ways. So I should mention, we did this in a large archival data set of GAIN interviews pulled from a number of projects that have been done over the years, a number of settings, all among youth on probation, looking at over 3,000 youth, and each of them had a baseline interview and then 1 to 4 follow-ups over the next year. So we're able to look at not just what did they say initially, but what did they report actually happened over the following year. I should also just mention, because these were archival data, there were some cases where the scale items that we had in our data didn't match up precisely with what's on the eConnect screen. So this really is looking at kind of a very close analog of that algorithm. So with all my disclaimers out of the way, like I said, we looked at a few things. So first, we just looked at how well do these classifications, so basically whether you're in tier 1 or tier 2 or tier 3, how well does that predict what happens in the future? Whether, youth actually makes an attempt suicide, or, gathers means or makes a plan for suicide. And so just at that first step, we found, number one, the classification does predict kind of future risk for all of the indicators we looked at, including for suicide attempt. Number two, so I already alluded to, we know past behavior is the best predictor of the future, right? Mm-hmm. So even just knowing, a youth has attempted suicide in the past, that gives you a lot of information that they're at increased risk. So, but we found that even kind of adjusting for that, even over and above the items directly about suicide risk, this classification still kind of added value in predicting level of risk. So by incorporating these other factors like mental health, like substance use, like the recency of symptoms, we're able to do better at saying who's at most risk than just by asking about things that are kind of directly about suicide. And then, we did find, not just, again, going back to it's not just a yes, no, black, white thing. We did find that, the increase in risk really is linear, that, being in tier 1, your risk is higher than tier 2. Risk 2, your risk is higher than tier 3, and so on. That is kind of one set of evidence that, we really are able to predict what we say we're predicting. And then finally, and this may be a little too in the weeds, I'll let you decide that in the editing room, but to kind of put a more precise number on just how accurate this algorithm is, we looked at what's called the AUC. So that's area under the receiving operating characteristic curve. So we'll just call that AUC to shorten things a little bit. So basically, this is a way of quantifying how well a tool ranks people from lower to higher risk. So basically, if you're just flipping a coin for everyone, and it's a pure chance, you'd get like 0.5. If you're predicting everyone perfectly, that would be 1.0. So we found that our tool is about a 0.7, right? So we're doing better than chance. Obviously, in an ideal world, you'd want to see 1.0, but suicide risk is influenced by a lot of things. It's very difficult to predict. And that's where, kind of what you alluded to of our performance being higher than some other instruments. If you look at how other screening tools perform in the real world over a similar time frame of a year long, 0.7 actually seems to be really good, that we are capturing more youth who may be at risk than other similar tools have reported capturing.
Impressive. So we touched on the role of probation officers in this process. We know that probation officers have limited mental health training. How did the design of eConnect overcome that?
Right, absolutely. So I think that comes down to not just the screening tool itself. So, a set of questions that, youth can answer on their own and that have been validated and that we know, do kind of capture important things about behavioral health need and risk. But I think kind of the classification algorithm, which, again, was kind of the focus of this particular study, is really key there because it is, on the one hand, taking away the need to have kind of expert interpretation of, of looking at all of these data points in terms of where youth are in terms of their symptoms and their history, and kind of needing to have that level of clinical judgment to kind of draw conclusions about not just is this youth at risk, but, do they need to go to the ED, or are they okay to just, refer, or, et cetera. By taking away that kind of that being laid all on the probation officer to determine themselves and kind of automating it based on kind of what we know from the literature and from, best evidence-based practice. So it's really kind of having sort of evidence-informed decision-making kind of in your pocket there. So I think in terms of specifically probation officers not having mental health training, because again, that isn't necessarily their job description.
Sure.
That's a big piece. And then, I think the other barrier isn't just training, but just time. That not just assessment and interpretation, but especially connecting youth to services and actually making sure they get into services is a very heavy lift. And so, I think that's where the other component of eConnect, of having these referral pathways that we've worked with agencies to put into place, really helps, where it's not just this youth needs help, do something, but this youth needs help, and this is, you can refer them here.
Which is sort of the third leg, which is to say linkage.
Exactly.
So if you can unpack that a little bit, and if there's anything that came out in this study about the linkage component of the eConnect system.
So in this particular study, we were pretty focused really on just the accuracy of the classification itself. But, we do know from our prior work that eConnect is really effective in increasing linkage. So, in our kind of main trial, where so previously we had done a trial of eConnect across 10 county probation offices, and we found that eConnect had a really huge effect on increasing the rates, one, at which youth were referred for treatment. So when a problem is identified, how many youth actually end up getting a referral, and then two.
Well, Casey, if I may interject, now, how does that referral work? Is it a probation officer that puts that person on the right path? How is that linkage facilitated?
Yeah. So, I mean, that's really where kind of these referral pathways come in. But yeah, it is a referral officer, kind of placing a referral and kind of sharing information about the youth with, a mental health agency or mental health provider in the area who, we know is going to be able to provide services that are kind of the right match for where that youth is at and what services.
Now that's not surfaced in the classification component. That's a separate, discrete piece, the linkage.
It is, but they kind of work hand in hand because the classification is what kind of gives us the information of like what level or what kind of services does this person need. So with the what the referral pathways are about are basically if this youth is at tier 1 and has really imminent risk, then you want to call this number, do this. If the youth is at tier 2, you can refer them to this agency by doing that, and so on. So they really kind of go hand in hand.
Yeah. So I'm assuming the predictive accuracy of the classification has great bearing on not just referring youth to the right resources, but perhaps to sustaining that engagement with those resources, which is obviously very important.
Yes, no, 100%. And we know from our prior trial that is also something we see, not just that youth who are in need are more likely to get referred, but once they are referred, they're more likely to actually connect with treatment. So, previously, even youth who are referred often are not actually showing up or completing an intake or going into treatment. But after putting eConnect in place, those rates are a lot higher because I think just as you say, the referrals are kind of more appropriate and better matched, as well as the fact that, we've kind of worked to make sure that the services are actually available, where we're sending people.
Now, is this is sort of this eConnect process a one-off, or are they periodically required to come back into the system for reappraisals or self-assessment?
Right. Well, so that's an interesting question. So currently, or, as it's been implemented in the projects we've done so far, it has been more of a one-off kind of done at intake, kind of to assess when people are coming in, what they might need, and then connect them to services. However, we have been looking at, in other projects that we have proposed or are working on, making it something that is repeated over time, which is, I think, would be really beneficial. Both clinically, you want to see if a youth did have a need and was referred, you want to see, has that need been addressed? Is there still need? Or even if a youth didn't have a need at intake, it doesn't mean they're not going to, at 3 months, say. And then from a research point of view, that would also give us a lot more information. We'd be able to kind of more directly do what we had done in this project of saying, okay, how well does what a youth or what our classification is saying at baseline correspond to what is actually happening in the future? So that's a direction we're very interested in going in.
Last question, Casey. What are the next steps for scaling or adapting eConnect, and what remaining research questions are most urgent for suicide prevention in justice-involved youth?
So in terms of scaling,
I know it's a big question, but
yeah, absolutely. So, for scaling, I think eConnect is really well suited for juvenile probation because it's, as we talked about, it's a setting with tremendously high need and at the same time pretty low resources. And unfortunately, there's no shortage of settings like that. Schools is another one that comes to mind, right? But other child welfare agencies, emergency departments, like I think there are lots of places where there are tons of youth who have, really high level of risk who are showing up, and currently that's not getting identified, or, if it is, providers on the front lines don't necessarily have the tools to know what to do with that or to be able to connect people to services. So I think the biggest area for scale I see is just kind of adapting it to other settings. And in terms of research, I think a really key thing is actually going to be what we talked about a moment ago of looking at how this unfolds over time. So, whether repeating assessments adds value in terms of, identifying who needs services and getting there. And actually another thing I think will be important for us to look at is, so based on the data we've had, what we've looked at in our prior studies is, who gets identified as needing help, who gets referred, who initiates treatment, so they attend an intake. And we've been able to improve those things, which is great. What we don't really know as much about is what happens after that. Are youth actually staying in treatment? And crucially, are there is their suicide risk being reduced? Are their symptoms, being effectively reduced? So that's something else that I think will be really important, and that we're hoping to look at in future projects, of kind of looking further down the service cascade, as we call it, of not just, okay, we got them to treatment, but what's happening once they're in treatment, and are there other things we can provide just from our tool and an assessment point of view to improve that further.
We're going to have you back on when you investigate this a little bit further. And again, Casey, congratulations for having this study selected by the editors of JCAP as one of their favorite studies, published in 2025. Again, the title, and it's linked in this description, is Predictive Validity of the eConnect Suicide Risk Classification Algorithm in Youth on Probation. Casey, thanks so much. I really appreciate it.
Thank you. This has been great. I'll be happy to come back anytime.
Absolutely. And among other fascinating things, I learned that DeKalb, Illinois is what? The capital of barbed wire, or the place where barbed wire is invented? What exactly is that now?
The birthplace. Yeah, it was invented.
The birthplace
yes.
of barbed wire.
Yeah.
Very, very impressive. Casey, thanks so much. Do appreciate it. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.